Good morning. My name's Julie Rosenberg, and I am speaking to you from Gadigal country this morning. On behalf of us all tuning in today, I pay my respects to elders past and present. We have, and I was just saying before we joined, this is our final session. How quickly a month goes. So this series is going to have a look at health options. The background to this, in case this is your first one, is we thought after not just the USAID shocks in decreasing aid, but the trend right across the world, whilst we're sorting out what that future means and looks like, and amongst the chaos, what we 100% know is that the work has not disappeared. The work continues on. The needs are exactly the same. There is a lot of confusion, and we will work towards whatever the new look looks like with a combination of resistance, reform, revolution. But for the meantime, the work needs to continue, and we're lucky enough that we're partnering with ACFID today. I probably didn't say, actually, I'm Julie Rosenberg from the Australian International Development Network, AIDN, and we're really pleased to be partnering with ACFID and hearing from partners who are working directly on the ground about the impacts that they're suffering and feeling. I'm going to hand over now to ACFID CEO, Matthew Morey, and he's going to introduce each of the panel that we will be listening to today, and there's a strict timekeeping, but I would suggest and recommend that you use the chat function and throw in anything you've got, comments to anyone, chats. We would love to hear from you and get your thoughts on it. And there'll be time at the end so that we can circle back. But for now, let's on with it. Matthew, over to you.
Yeah, thank you very much, Julie, and great to have everyone with us today. I do want to start again by saying thank you to Julie for the partnership with AIDN, looking at how we can make this connection between Australian philanthropy and ACFID members and the gaps that have been created by some of the challenges in the changing donor landscape, especially with USAID cuts. So it's been a good 4 weeks. It's been a great opportunity to connect. We've told every one of these groups that these sessions actually have a life beyond just this hour because we are recording, and we will be sharing this with the wider AIDN network and others who might want to watch it later and consider how they might be able to get involved in some of these projects. So thank you for everyone who's here today. We have 7 different organizations who are going to talk about their programs. This week is a focus on health and the impacts on the health programming. We chose, over the 4 weeks, we chose 4 different topics, and they were actually driven by where our members were telling us the greatest gaps had been created and the greatest impacts of these unexpected aid cuts. And health was one of those areas that had a really big impact. I do want to paint a picture before we get into the project-specific work to give everyone a sense of just the landscape that we're in. First off, for those of you who don't know who ACFID is, we are the peak body for the 130 member organizations who are part of ACFID and represents really the breadth of organizations involved in international development and humanitarian work around the world. The mosaic of our members' logos is seen on the slide. You can't really read it, but you can get a sense of the breadth of number of organizations that come together and share this joint work of making the world a better place and addressing these challenges of poverty. The next slide gives you a sense, as I said, of the landscape that we're in, and with the decline in aid, not just the USAID cuts, which are material and really significant, but actually over the next 4 years or so, we're expecting to see up to a 50% reduction in overseas development assistance. That's money that governments have committed to tackle these poverty issues around the world. You can see some of the nations who have already foreshadowed cuts to their upcoming aid budget, often shifting spending from aid to defense in light of some of the bigger changes happening around the world and the way, again, knock-on effects of the US government reductions as well. The next slide is a reflection of how ACFID members were impacted by these cuts specifically. As it says, over $400 million in programming that our members were involved with, over 100 projects. And notably for this session this week, $53 million in programming that was specifically involved in health work that has been impacted. As the next slide shows, and the next slide shows some of the areas that, again, taking from the survey from our members of what types of health programming have been directly impacted. I won't read through all 8 of these boxes, but you can see the breadth of it. And I will say, as the 7 organizations are presenting, you'll hear different examples that reflect some of these different areas of programming that have been hurt by the USAID cuts. The next slide gives you a sense of why the US cuts matter and why health is impacted. If you look at that pie chart on the right, you can see that this is of the global commitments in terms of giving to health programming around the world. The US makes up about a third of the overall budget, over $8 billion. And the expectation, as the text says, is that there could be up to $10 billion of funding cuts actually to health-specific programming. And the ripple impact that the USAID cuts have had is that programs like the Global Fund and Gavi, the Global Vaccine Alliance, and other work is also funded or has back donor support from the US government as well. So some of these big global mechanisms are directly impacted and are starting and are living into those impacts and how they're having to reduce their programming and make really difficult decisions about cuts. This slide gives you, again, a picture of how ACFID members have been impacted on the health program cuts. The majority of the impacts are in the Africa region, and then you can see it rolling out across the different regions in terms of the dollar impacts that I've already mentioned. We are going to be hearing examples of projects from Africa, the Pacific, South Asia, Asia. And so you'll get, again, a flavor of the range of programs that have impacted. And most importantly, specific programs that that can absorb funding and are looking for additional support as they present. The final slide is just bigger of the global picture. It reflects that in a little bit more detail, where our members' health work is, and the more shades to blue are more shades to the darker orange, and red is kind of the bigger programming in terms of dollars. So with that introduction, I do want to hand over to our first speaker, which is Greg from the Leprosy Mission, who's going to be, I think, starting with a program in Africa. So over to you, Greg.
Thanks very much, Matthew, and hello, everybody. Thanks for this opportunity. I'll just briefly introduce the Leprosy Mission for those who don't know it. We're a very focused charity, as the name suggests. We've been around for 150 years. We work in 30 countries, 30 different organisations in a kind of fellowship structure. Australia is about the 3rd largest in terms of funding projects around the world. We have a 000 strategy, which is 0 transmission of leprosy, 0 new disability caused by it, and 0 discrimination for people affected by leprosy. And the good news is we're in the last leg of our battle with leprosy, that the expectation is within a decade we should be able to achieve that breaking of transmission, and the other things will flow from that. So it's an exciting time to be involved. I've only been CEO for the last year and a half, so I'm still learning. We also do a leprosy adjacent work, which is things like neglected tropical diseases, disability, special interest in orthotics, livelihood and social enterprise work. We own hospitals, especially in India. We own 12 leprosy-focused hospitals that also provide other services on a pay-for-treatment basis, but all the leprosy work's free. And we work hard on the discrimination and inclusion aspect of what we're doing. And we've just had a new report come out from our UN Special Rapporteur about human rights issues around leprosy. So they're all important parts of our work. The project I wanted to present is in Nigeria. It is an ANCP project. We receive funding, and we are now in the second phase. the second 5-year phase of the project. Briefly, the impact of US aid is both up and downstream from our project. The main impact being the incredible loss of jobs in the NGO and health sector. I think the estimate is about 21,000 jobs will be lost in Nigeria as a result of the US AID cuts, and with a huge impact on health services in particular. So we expect an increased call on our services over the next period of time. Our main work is through health clinics, which we do in community, with a focus on skin health, but also on mental health, flowing on from that. Our first 5-year project was in one location, in Zamfara, and we've now expanded it into 2 other locations, 2 other states, Nazawara and Benue, excuse my pronunciation. So these health clinics are a partnership with the community and with the government, aiming to integrate a neglected tropical disease control program into the general health programs, and to improve access to quality healthcare services in those 3 states. Generally, we're looking to educate 80% of the population in those 3 states with proper information about NTDs, good sanitation hygiene practices, 6,000 people to receive health services through the clinics, and also to promote self-advocacy in 12 communities so they can do a better job of representing their needs to local and state governments. Our needs across the period are estimated in terms of the impact on the availability of labour. So we're looking to try and find next 150k a year across the next 4 years of that 5-year project, so that we can make sure we can fill the gaps in healthcare worker issues, but also expecting a need to expand our clinics beyond what we're currently doing because the government health services are so underfunded. So we'd like to move from 3 locations to at least 5 or 6 states across that period of time. My international programs manager visited last year. He went to one of the clinics that's sort of outside a shopping centre in Kuali, which is about an hour out of Abuja. There's a big banner announcing the health clinics there for the day or for the week, and people sitting under chairs outside of it, about 400 people on that day, receiving their services, local hospital and pharmacy staff, integrated with some government workers. The leprosy mission staff are there. And from that particular day, about 30 health referrals for drug treatment, surgery, and mental health counselling. And that's an average for the day in any one of the locations. The last thing to say is leprosy mission's in an interesting position in Nigeria with a very good relationship with the health department, the federal government. This year, we helped to restore the supply of leprosy medication, which had been on hold for a year due to bureaucratic and political issues. Through the work of the Australian High Commissioner there, we helped to re-establish that in March. So people who had not had any treatment for a year are now finally back onto their treatment. So we're in a good position to work with the authorities in order to provide these services. I think my time's up. Thank you very much.
Your time is up. Thank you very much, Greg, for sharing. And I know Emily stuck it in the chat, but I'll just make the point as well. If you do have questions that arise from any of these presentations, we'll have time at the end for some questions. You're welcome to stick them into the chat for people to prepare, or you could just ask them at the end. Peter from CARE is going to go next. So over to you, Peter.
Great, thank you very much. Let me just see if I can pull up my presentation. Matthew, can I just check? Can you see that all right?
Yep, it's not in presenter mode, so maybe you can switch screens. That's perfect.
Great, thank you. So, good afternoon, Australia. This is Peter Goodfellow dialing in from Dili in Timor-Leste. I'm the country director of CARE in Timor. It's a great pleasure and a great opportunity for me to talk with you all this morning. CARE has been working in Timor for just over 30 years, and we have a really well-established health and education program, which is predominantly funded by the US. And just about 10 days ago, we received a termination letter from US government, which basically is approximately 2/3 of our program portfolio. And I just wanted to share with you just a few statistics about malnutrition in the country and some of the work that CARE and the government are doing to combat it. So just briefly, I'll say a couple of words about our work here, and then I'll show you a video of about a minute and a half, and then a couple of statistics, and then next steps where we're going. So CARE predominantly focuses in rural disadvantaged parts of the country on women and girls, and our main areas are education, health, economic empowerment, and women's voice. And just wanted to particularly highlight that approximately half of all children in the country are stunted, got one of the highest rates of stunting in the world, and very high rates also of wasting and malnutrition. And so to address that, CARE has been working with the government to support the school feeding program to provide school meals every day to children, and that's summarised in this video.
Kami iam ni sekolah ni ansa ini su anu de tibune merenda lai kulanda ruwa tolu ne sidau ki sira gosta sira lahana imbara tamba ko han sirne bele aizuda sira aizuda sirna stomach I tamia class sira mas lahate ketung sai no sira ansa filamos ho content.
Dewi hang durante tenya tina dan larang tulung ida bala tu baru onan lalu sir hang ko remata ya durante ne hai kata hane bodun beneficio lavar sira tambah lavar sira sekolah masira anesang badina step tv so lavar sira contenti ho han meren la sekolah debe durante ne hatu dalmai.
Okay, so just briefly, what we've learned through implementing this program, it's been running for about 6 years. It was scheduled to finish in 2027, but what our data has shown is that most children have quite a lot of carbohydrates and leafy greens in their diet, but very low rates of protein. So we've really focused on ensuring that when they're at school, not only are they getting a meal, but they're getting a protein-rich meal. And what we've seen is that kids that have that regular school meal with high protein generally have increased literacy scores by 8% compared with their peers and double the average reading fluency score. Given that this program will be terminated on the 30th of June, we are currently putting in place a mitigation effort, which is to really focus in on which are the most high impact parts of the program and try to continue those starting on the 1st of July. And that's building on our research, ensuring there's a protein-rich supplement at target schools in the most malnourished parts of the country. We'll be working with the Education Ministry to ensure that particularly those that are at risk of cognitive disabilities are supported. And we'll also be working with households and communities to address nutrition practices in the home. Appreciate time is short, so I'll leave it there. But if any questions, please come back to me. Thank you.
Yeah, we'll have time for those questions. Thank you, Peter. And you mentioned in that project a bit some partnership with WaterAid. Actually, our next speaker, Bernice, is from WaterAid, and I think we're going to shift to PNG and hear about some of their work there. So Bernice, over to you.
Good afternoon, everyone. doesn't look like my slides are going to work for me, so I may have to just talk to you. I had some very nice photos to share. As mentioned, my name is Bernice Sarpong, and I'm the technical lead for health in the region, working with WaterAid Australia. And since about 2020, WaterAid has collaborated with the PNG, Papua New Guinea's National Department of Health, to enhance water sanitation, hygiene, environmental cleaning, and healthcare waste management in healthcare facilities. And these are the 5 essential WASH domains for healthcare facilities determined by the World Health Organization. I had a graph which really highlights that nearly half, so 49% of healthcare facilities in PNG do not have basic water services, and 96% do not have basic sanitation services. 86% lack access to hand hygiene at points of care, and 97% of facilities incinerate healthcare waste in open pits, which is an environmental and health hazard. With support from the Australian government through its flagship program, Water for Women, that ended in 2024, WaterAid has been partnering with the National Department of Health, and we help support the setup of a WASH technical working group, which is specific to washing healthcare facilities, and developed a national roadmap, essentially a blueprint to accelerate WASH in healthcare facilities for the next 5 years in the country. Along with the roadmap, a national guideline was also developed, and that provided minimum standards for washing healthcare facilities. And that was developed in partnership with the NDOH, but also other key stakeholders in the country working in healthcare settings. And both documents were launched by the Health Secretary in 2024. And I think the project really achieved some key system strengthening within the health system of PNG. We also supported the NDOH to socialise these new guidelines in 5 provincial health districts. However, due to funding cuts and also the Water for Women Fund ending in December 2024, the opportunity and the momentum to expand the program nationwide has come to a halt. We recognise that environmental cleaning is a really critical domain for WASH in healthcare settings. It's key to reducing healthcare-associated infections. It's key to reducing complications that can arise for mothers and newborns during the birth process, and can certainly increase mortality rates for mothers and newborns if not done well. Environmental cleaning is foundational to infection prevention and control. And the slide that I would have shown you shows that 70% of healthcare facilities in PNG do not follow proper cleaning practices. WHO has actually developed some key steps that governments can take to help achieve universal access to quality care, and it's recognised that WASH is a prerequisite for quality care, and particularly important for safe management of childbirth. And through the impactful partnership between WaterAid, the NDOH, and other actors in the country, PNG has achieved the first 3 steps of these 8 practical steps. As mentioned, they've developed the guidelines, they've developed a roadmap, and have started the workforce development by the socialisation. The next steps that we would love to see take forward is support the government to develop a comprehensive training package around environmental cleaning and set standards for environmental cleaning protocols, which we see as critical to protecting public health, strengthening health security against threats within the country and within the region to an already fragmented health system. The project needs an additional $1 million over the next 2 years to maintain the momentum and advance the key actions in this roadmap. So that's all I wanted to share for now. Thank you.
That's great. Thank you, Bernice. And I'll just mention at this point, the PowerPoint presentations, as well as information about the projects that are being discussed, will be shared with participants after this. So even if you don't see it now, it'll still be something that we do share with people who are interested to look at those details. So Thanks very much. We're going to go to, I believe, Afghanistan, and Greg Hewson from Cheer Fund is next to share.
Thanks, Matthew, and lovely to have the opportunity to join all of you. I've got a presentation, so I'll see if I can do that and just get that sorted. Hang on. Okay. Can you all see that?
Yeah, we can see that.
Okay. So firstly, I think in the run sheet, I had planned to talk about a project in Somalia, but then I thought this is a bit of a different type of health project and something that I think would be really good to share with people about this opportunity. Tear Fund Australia works through 4 local partners in Afghanistan. We've been working with some of those partners for over 40 years. And we choose to work in Afghanistan as one of our focused areas. In fact, it's the country that we have the highest contribution to, because when we look at those global indexes of poverty and inequality, it's right at the top, and that is obviously only increased since 2021. As people will know, Afghanistan is facing one of the world's worst humanitarian crises through the political upheaval, and some statistics there about an estimated 50% or 23 million of the population in needing humanitarian assistance, and there's an increasing high level of food insecurity. There's obviously the other social issues, particularly for women and girls, are ongoing and significant. The project that I wanted to share is with one of our partners, International Assistance Mission in Afghanistan, and it's a mental health response that they've been doing, and they're now in their 3rd year. An overview of the project: the mental health response has, up until recently, received UNICEF funding. However, that is being reduced, and that's likely to increase that reduction because of the USAID cuts. The project already had a shortfall, so this is further impacting the team and the ability to work in what is an incredibly challenging context already to provide a really significant service. And that service is a community-based mental health program that strengthens the capacity to promote mental well-being for people with psychosocial disability at family level, at the community level, and also at the local and secondary health services as well. And so working through those local services is a key part of the program, and what we're keen to ensure continues. It addresses barriers to social inclusion, improves mental health outcomes, attitudes and behaviours, and aims at mental health system change as well. So working both the personal but also at the structural level. Our partner, IAM, has, as I said before, a long history of working here, and so over those years has been able to really establish strong relationships with key actors on the ground. So that systems change aspect is a really critical aspect of that. Work is undertaken with cultural and gender sensitivity and closely cooperating with authorities, plus those who have psychosocial disabilities, communities and leaders, civil society, health providers, families. So the situation, hang on. The shortfall of funding, as I said at the start, is initially just under 50,000 US, but that is expected to be further impacting towards the overall annual budget of 148,000. What this means so far has been felt by staffing salaries, training activities, and just the loss of that ability for the team to get out there, and has put a really significant handbrake on the project's ability to function. So I'm really happy to take some further questions or talk with people more, but that's the project that I wanted to update people on. I've got a photo here of On the right, my colleague James, who visited the project last year and was able to give a really great update on the project effectiveness. That's obviously before the recent US AID cuts. So thanks, Matthew. I'll stop there, and yeah, happy to take questions either later on.
Okay. Thanks, Greg, for highlighting that program around mental health and well-being in Afghanistan. We're going to shift gears and hear from Ben from Opportunity International. I believe he's going to talk about some creative health financing and some needs there.
Yeah, great. Thanks, Matthew. Encouraging and also quite devastating to hear all of these updates, isn't it? There's a lot that's been happening to a lot of people, a lot of livelihoods. Look, I'm here to talk about Opportunities Health Finance Project, which is operating in India. So thanks, Matthew, you're right there. Opportunities Health Finance work, well, Opportunity in general, actually, we're the only organisation working at the intersection of women's health and women's economic empowerment at scale. And we've, for the longest time, 50 years, we've been a microfinance organisation. And since 2012, we've been expanding our health program. So the current footprint is across 4 countries, and since 2012, we've reached over 8.5 million direct beneficiaries. We do have plans to continue that growth and expansion. You can see here on the map that we're talking about, adding an additional 6 countries in the next couple of years as this program takes shape. For the most part, we've done this through our community health leader, community health worker education model, where microfinance is coupled with all that microfinance mobilization network, and those last mile organized communities have been supported or used as a delivery mechanism to get essential health messaging to last mile communities. Because what we know is that 1 in 5 households globally are actually served by these microfinance institutions. And we also know that there's 1.3 billion people each year are pushed back or affected deeply by medical expenditure, which is pushing them back into poverty. And so the work that Opportunity is doing within the health finance space, which is more of an innovative model on our side, it's a couple of years in now. We're working with a local implementing partner called Uplift Mutuals. And they've been doing some really incredible work by, I'll get into the projects actually in a minute, but the need that we see and the devastation, I guess, this kind of double-edged sword that many urban poor households that are living in and around Mumbai, Pune experience is they're not able to get access to free medical care. They should be able to, but for whatever reason, there's lots of different challenges. Very happy to take questions on that. But we know that despite sort of official government insurance policies being in place, that 95% of medical expenditure is actually out of pocket for these households. And so given these catastrophic medical expenses, they turn to loan sharks who charge anywhere from 60 up to 200% interest a year. And your classic financial inclusion organisations won't typically touch a health financing loan because it's not income generating and it's deemed as too risky. And so what we're doing with Uplift is assessing, through the needs assessment that we've done, we found that less than 1% of our target audience that are living in these urban slums have insurance. So they're incredibly vulnerable. So we're coupling mutual insurance with either health savings accounts or health loans. And you can see a few stats here that through the pilot, we've had 100% repayment rate, and that demand is greatly outstripping supply, and that most of the people that are coming to us for these loans are women, and a large majority of a large portion of the loans that are used are directly to cover childbirth related expenses. And so to cut straight to the chase, what we're seeing within this project is pretty devastating staff cuts. So over half of Uplift's team have been let go. And these are the team not providing the financial services per se, but all of those 3 elements that I showed earlier, they're underpinned by primary care. We know that 90% of the healthcare needs that people have can be addressed with preventative and primary healthcare services. And so by coupling these financial products with more accessible and insured access products, that means that there's over $200,000 in a funding shortfall for this current year. We do expect that to compound for the years to come. And so while we're directly, Opportunity itself is funding the financial side of things, it's that community healthcare provision that we've seen the USAID funding cuts hit hardest. And as a personal anecdote, I know I'm out of time, we know that some of the senior staff at Uplift have been going without salaries to make sure that those frontline services are funded. So they're desperately feeling that pinch.
Great. Thank you, Ben. And look, I mean, that point I think is one well taken, and one I've heard as I've talked to our members and their partners around the world, saying how many organizations, even without pay, are still trying to get the work done because they're so committed to that work. So we have two more speakers that we're going to hear from. The next one's Nicole from Caritas. So over to you, Nicole. And I think talking about the work in Gaza.
Yes. Thank you, Matthew. I'll just quickly share my screen. I'll just pop him in presenter mode. And that's sharing okay, is it, Matthew?
Yeah, we can see that. It's not in presenter mode yet, but I can see the screen.
Now it's in presenter mode. Sorry, that was my fault. Anyway, thank you again for the opportunity to be able to speak to you about here what is a very important project. For us, it's with our partner, Caritas Jerusalem, and it's a program that centres around mental health, and a key part of the program is around prosthetic care. Really quickly about Caritas Australia, we've been working for over 60 years with the most marginalised and remote communities here in Australia and overseas. Last year, we supported our partners across 36 different countries and 57 different programs, and we work within a very large confederation called Caritas Internationalis and their network. And Caritas Jerusalem, our partner in the West Bank there, is part of that confederation. So very quickly on Caritas Jerusalem, I don't go into too much depth about the situation in Gaza. I think everyone's quite well aware of that at the moment. But just to say that our partner has been providing aid and socio-pastoral support since 1967 in the occupied Palestinian territories, and they're very much involved in Gaza and in the West Bank, and they have great networks of community-based organisations whom they work with and different local government ministries and the like. So they're very well embedded to be able to provide the care that they need to. At the moment, really, they have constantly been under great funding pressure, but that has certainly increased. And the need for them to be able to continue their work is incredibly important, but the funding cuts are having an impact on what was already, quite a tight funding environment for them. The areas of work that this specific project is in psychosocial support, so mental health services, general primary health services, and prosthetic care. So, as I said, I won't go on too much about the situation in Gaza because we don't have too much time, but just to focus in on the fact that more than 110,000 people, and it probably is a lot more than that, have been injured. Among those, over 4,500 have undergone amputations, and at least 800 of those are children. It's a really catastrophic toll, and it really underscores the need that we must continue this intervention with prosthetics and intervention to deal with the trauma that people are dealing with. Also, too, intervention to support. We hear a lot about the hospital system over there, and our smaller clinics are really important in being able to give the ongoing care to people that they need. So what would the funding support provide? It would support around 32,000 patients, giving them access to healthcare services, particularly in areas with severely damaged or destroyed healthcare infrastructure, prioritising women, children, elderly, and the disabled. As I said, the ongoing crisis obviously has also had a hugely traumatic impact on the communities, and this funding will allow us to be working with 500 children and their caregivers in a real mix of individual and group counselling. People are traumatised, children are there, but we're able to help them deal with things like their nightmares, etc., and really being able to get through their trauma and build some resilience with different sorts of group and individual activities. So this funding would help keep that going. The other area is around prosthetics. So we're working at the moment, Caritas Jerusalem's working with the Polio Centre for Artificial Limbs and Prosthesis in Gaza. And this shows you some of their work. It's life-changing, and it's not even just the physical side, but it is a real show of resilience for people, a real sign of resilience that they can continue their lives and what will be a rebuilding. So this will really allow us to work across these 140 different prosthetic services to individuals, which is really, really critical at the moment. So we do ask for support in any way with this project, because as you'll see on this slide, it does have quite a funding shortfall. It is a bigger project than this, but the funding shortfall is really impacting those numbers that I spoke to. It is around 2.5 million. We are working across the Confederation and with other donor opportunities to fill this gap, but do need whatever support that we can to keep what's really important work in Gaza continuing. Thank you.
Thank you very much, Nicole. The last presenter today is Brendan from the Burnett Institute, who I believe is going to be talking about the challenges of addressing the HIV pandemic in the Pacific. So over to you, Brendan.
Thanks, Matthew. I'm just calling in from Papua New Guinea at the moment, so my internet's just a little bit dodgy and no presentations. So Burnett Institute is a medical research institute and accredited NGO. Our focus is on infectious diseases elimination, harm reduction, health security and pandemic preparedness, and women's, children's and adolescent health. So we are very much focused on equity in global health. The impact of I'm going to speak a little bit more broadly initially. The impact of the executive orders in the research context is a little bit broader, I guess, than just the USAID cuts. Obviously, those cuts have impacted groups like PEPFAR, WHO, UNAIDS, UNICEF, Global Fund and Gavi, as Matthew mentioned. And all of those organisations are ones that Burnett partners with in different ways, either through funding or collaborative research. A lot because of the unknown factors for those organisations, we're expecting sort of the funding impacts to really hit in 2026 onwards, really. So we're trying to understand more of the future impacts of our work and engagement than really responding immediately at the moment. The other big piece of uncertainty for us is the current restructuring of the UN bodies and organisations, and so that's a big piece of work in progress, and trying to understand that is very much one of our watching briefs. The other factor for us that from the executive orders are the cuts to the National Institute of Health, the NIH in the US, and their research programs. And that's affected the research community globally in sort of quite a major way at the moment. At the moment, everything is on hold with announcements coming in, I think, September, October this year. And teams are allowed to spend on their current annual plan. However, the current orders are for no a US organisation with NIH funding cannot contract any international organisation or engagement. So what that means for us is while there's a loss of funding for our components of joint research activities. What it's actually meant is whole research sites of significant value being closed and cut. So clinical cohorts just are not operating at the moment. Countries like Malawi, Zimbabwe, other African groups that we're engaged in and countries we're engaged in have significant research activities that have been lost completely, and it's very difficult, if not impossible, from an ethics perspective as well to restart those after cuts. So that's some of the broad stuff that we're dealing with or reviewing. Obviously, some of the cuts are related to PEPFAR and HIV. Some of the modelling that we've done indicates that with not just with USAID, but reductions from the UK, France, Germany, and Netherlands to HIV spending. Globally, there's about a 24% reduction in the international HIV expenditure, plus the reductions in US foreign aid there. So one of the programs that we're working on in Fiji in particular is a peer support activity. There is a HIV epidemic outbreak essentially that's been occurring in Fiji with over 1,000 cases reported up to September of last year. That's 3 times of 2023. DFAT have recently announced increased spending to support that outbreak. And what we're trying to do is a peer support activity as an adjunct to that in partnership with the ministry, community partners, and several other partners. So peer support is important to keep people to daily treatments and staying connected with healthcare services. So this program is really to work with community-led organisations to create a network of peer counsellors across the country, a localised peer counselling toolkit to guide and inform their work. So that program over 36 months has a shortfall of around $600,000. But that's just one example of the work Burnett is working on. Thank you, Matthew.
Thanks, Brandon. Yeah. And I mean, as you have shared, but I think we can understand from all the different projects that have been shared there's a generational impact to some of these reductions and the ways that they're being rolled out. The great thing about these seminars is there actually are some specific ways that we can actually respond and make a difference in the lives of some of the people who've been impacted by these cuts. So thanks to all of the speakers who have shared. Thanks to those of you who've called in from overseas as well. I'm going to hand over to Julie now, who's going to wrap it up with the Q&A session and any closing comments. So over to you, Julie.
Emily and I were just sort of texting, going, that is like channel surfing through a world of big issues and reduced funding. I don't have any questions myself, and sadly I don't have any answers either. It'd be way better if anyone's got any answers to any of these to throw them in the chat. Are you finding that philanthropy is stepping up at all? There was an article the other day going philanthropy was way better during COVID. It really rallied. I know that AIDN itself was moving lots of PPE. There seemed to be direct things that people could do, but I would love to know about any of your experience that we could kind of highlight and see if we could replicate, build on. Is anyone, like, I'm speaking tonight at the Life You Can Save released or set up a rapid response fund It's slowly building traction, but I would love to hear how you've been supported, I guess.
Happy to take a brief stab at this. Thanks, Julie. I think for us, in some ways, it's almost too early to tell. I think over the next few weeks, with the end of financial year approaching, we'll see more of that. I think there's a balance between, we're seeing our supporters being very generous and faithful and intentional through their giving, not necessarily drastically increasing their giving, but there's a solidarity in that. And then I think there's also a tension between supporters that love and trust the work have tended to be inclined to give unrestricted funding. And so in some ways, until we know sort of how the end of financial year pie falls, we don't exactly know the impact on these programs specifically. So there's a bit of a waiting game, but it's a great question.
Yeah, thank you, Julie. It is a good question. We at Tier Fund have gone to our donors specifically asking for them to contribute to the gap in funding during this end of financial year, and have tried to spell out what that is. So not just the project that I've spoken about today, but the overall gap, and to ask people to consider being able to at least bridge that gap temporarily. But the bigger picture is the ongoing systemic gap. So there's sort of a dual conversation that we're trying to have, which is the present reality, but then the long-term reality, which is a different conversation. So yeah, and there's a lot more work and talk that needs to happen in that front in particular.
And Greg, you were saying that you were impacted by UNICEF not getting funded. So UNICEF funds TIF, like, are you in a collective?
UNICEF jointly funds that project that I was referring to. Yeah. So that funding, because of their exposure to USAID cuts, has meant a reduction in that, which is going to continue to compound. Yeah.
Yeah. I'd love to learn more about that. Like, I don't think we hear enough about INGOs working together, like, and receiving joint funding, and how that impacts. I mean, we had our advisory council during the week, and spoke to a lot of people who are funding local leaders. And while they are very rarely impacted by USAID, they are picking up patient numbers as government clinics close everywhere. So that's the thing for them. They were never funded by USAID, but now they're going to have to stretch even further, and they were already stretched.
It's such a good point. I mean, so many of the projects that we support, the actual project hasn't been directly impacted, but it's the overall partner organization. The USAID funds are used for staffing, they're used for infrastructure, capital expenses, etc. So when you take out that aspect of the funding, it becomes very hard, even if the specific allocated project funds that we give to and others give to, you're left with an institution or an organization that's very hard to run. So that becomes a compounding, as I said, systemic issue.
And is health going to be one of, like, I would think if, like, everyone was just real, like, and everyone goes, right, this is the new reality. And yes, we will work our way through to a new reality, and and people will die in between. Like, this is absolutely chaotic. But is health going to be a priority? I would think that most people would go, yeah, like, we're going to keep working on HIV. We don't want to lose those gains that we've made. But are you finding that? or not really, like that you're getting, like you're all in a health bucket. We just went around all the, like you wouldn't be able to pick between any of you going, like you wouldn't be going, oh, well, you know, ours is better than yours type thing. Do you know what I mean? Like this is all in this health basket, which actually will, if untreated, will only end up imploding and costing the whole of the world, not just lives, but, you know, huge amounts of money.
I think that's good. If I can jump in, Julie, that's a great point.
They'll always interrupt me. Like I would just a little bit Guncha, I always go to like problem solving, and I'm finding it really difficult to do any problem solving in the scheme.
Yeah, I mean, because the scale, it's like a systemic problem. So I think one of the great things about the philanthropic sector is wanting to be strategic about that and wanting to align. I mean, you've got a group of people who here on the call who, you know, to some extent are all competitors, but want to work together for the greater cause. So there's a great kind of opportunity for alignment strategically, I think, that we all have to think together about how to solve these problems. And then
Is that happening, Greg? Like just on that point, are there convenings like that going on now? Because
Matthew's probably in a better position. Matthew's probably in the best position to answer.
Okay, yeah, great.
I
Sorry,
mean,
well, I didn't mean to interrupt you. We can come back.
go ahead, Greg. Finish your point, Greg.
I've forgotten my original point now, but it was
I do that as well. It's annoying.
an example in, I mean, I think that's right. The point was it might be great to calculate to some extent the economic impact of these changes, so that we have an argument, you know, that kind of negative argument you can make that if you don't support this, it's going to be worse. I think that's probably an easy argument to make at this point in time. But the other point I was going to make was just there are some sort of simple solves that I think can represent the pathway to success. Example from our work is Novartis produces the leprosy treatment drug for free, and WHO supports that, distributes it. The risk to WHO funding affects the likelihood that they can do that. If you can solve that one problem, leprosy medication around the world can still be supplied. So if you can find these sort of simple problems to solve together, then that kind of builds muscle and momentum for the more wicked problems that most charities are dealing with that are ongoing. So that would be one suggestion I've had, is try and find our specific problems we can solve well as an example of the sector cooperating with philanthropy and government.
If you find them and do them, shoot them straight through. So, because they are also the beacons of hope.
Exactly.
That's how people stay resilient, is you need, you know, here's me preaching to the converters, but do you know what I mean? Like the whole of the world, because I feel like most people are paralyzed at the moment. They don't know, and talking to philanthropists, they you know, they don't want to be knee jerk, as you said, they want to be strategic around it at a time when there's not a lot of strategy. Do you know what I mean? Like we're not responding to a strategic response, we're responding to just chaos.
And I think there's a great opportunity for resistance here because, for example, Novartis, I'm not paid by Novartis, by the way, but they, their CEO announced that they would continue to produce the drugs for free, regardless of what happened, which I think is brilliant, because then, you know, the charities can line up and thank them for that. And there's an alignment around that one issue that actually speaks really loudly, not just to our constituents that it's worth supporting us, but to governments and to other players.
Yeah.
Yeah.
And like strengthening those supply lines, right? That's what everybody talked about during COVID. I don't know actually whether we ever did that.
Right.
COVID just went away and we just thought, oh, it was a really good idea. And this is almost like another, like, here's another dry run, like COVID was a dry run for this one. So, yeah.
Yeah.
I think it's I see things a little bit broader than just the health sector. I mean, the impacts of these cuts are across education, the diversity, equity, and inclusion programs that are all running, girls' primary education,
economic, everything.
Everything, and in low-income countries, and particularly some of the Pacific Islands, for example, the impacts across the whole of the development sector or the government sector is massive, and I'd like to think the response needs to be not so sectoral. I think this is the ACFID sort of model of having the different sectors presenting is really useful. But the intersection of education and health is obviously well known, and we need to, I think we need to be looking quite broadly at how we can best both mobilise resources but ensure some of those alignments and connections are maintained.
Totally agree.
And then I would just say, and just fill some really critical gaps in the meantime, because some of it just can't wait for us to all get together and strategize. I think we need to do both at once. So there are some critical gaps that have to be filled immediately. Others can maybe wait for a bit more of a strategic approach.
Yeah, no, I agree. I mean, you've just got to keep plodding on. Matthew, is there any thought about pulling together groups of people to come up? Like, I mean, I guess I always look at the Sustainable Development Goals, and I reckon you could reduce them down to 3 where they intersect around, women and health and climate. But health is key. I mean, even Mum used to say, without your health, you've got nothing. I mean, it's the old adage. It's, but whether everybody turns their focus there to shore that bit up, I don't know.
Yeah, I mean, it's a good question. And yeah, there is a lot happening. I mean, some of what we saw already happening at the country level, it is a little bit topic and geography specific. But one of the things ACFID is doing is in the middle of June, we're actually having a summit where we're pulling together the CEOs from all of our member agencies to have this very discussion to say, how do we work differently? What are the opportunities? How do we collaborate in ways that can fill some of these gaps and think more systemically as well about the challenges we're trying to solve?
I'd forgotten about that. Simon Lewis is.
Yeah, Simon will he'll give a
there.
perspective from philanthropy as well. So
Yeah.
it's going to be that's one thing we're doing, but it's certainly not the only thing that's happening across the sector as agencies are collaborating. And Peter's presentation even pointed to the fact that a lot of these collaborations are pre-existing, and so then how do these agencies continue to think together about solving these challenges?
I'd love to learn more about that personally myself, how the INGOs do actually work together. Anyway, not this time and not this series, I guess. Maybe we could start a new series. We'll see. We've gone over time, sorry, and there are no other questions. I mean, the statement, I totally agree, and I do not understand why preventative health actually at times like this goes further down the chain rather than being thrown back up to the top. But I don't know. It's just the way it rolls. Thank you so much. I can't thank you all enough for making the time, and yeah, let's hopefully stay in touch.
Yeah, and let me close as well by saying thank you, Julie, to you and Emily at AIDN for helping to facilitate these discussions and make these connections, and remind everybody again that this will have a life beyond this 1 hour as people have a chance to view it and share that information. If there's things you haven't shared and you want from your organization on how you've been impacted and the needs for health, you could still get them through to Emily Morton at ACFID pretty quickly because we'll be sharing this out afterwards. But thank you everyone for being part of it, and thanks again to Julie and Emily for helping to coordinate it.
And for the work you're doing. Okay.
Thanks, Julie. Thanks, Matthew. Thanks, everybody.
Thanks, everyone.
Bye.